Brilliant. Welcome everyone. Good evening to the US audience and welcome to another episode of the Live Injecting webinar series. This is our third episode of the webinar series for the US audience specifically, but I've lost count of how many we've done across the Australia, UK, European markets so far. We're probably well into the 20s or more. And my name is Dr. Amrit Tiara. I'm the CEO of Derma Medical and very much going to be the clinical injector today on our Live Injecting webinar, which is going to be focusing specifically on the non-surgical rhinoplasty procedure, or aka nose filler or liquid nose job. And what we're going to be doing is we're going to be going through a real life patient today and specifically going through how I approach both from a safety perspective but also to maximize a cosmetic outcome a non-surgical rhinoplasty using dermal filler. Now, it's a procedure that in my clinic is very, very popular in the UK, and I perform probably around about 1,200 to 1,500 non-surgical rhinos per year in my clinic, specifically myself as well as my other injectors doing even more. And it's a procedure which for the patients allows them to have a non-surgical procedure, so no downtime, no bruising, no anesthesia required, the option for reversibility, much safer, the complication risks are much better, and something that now with the approaches with the higher density G prime fillers as well as the safety of aspect that we can use to deliver the product means that we can get very long lasting results for the patients. Now, it's a procedure which probably takes about 15 minutes or so when you're very familiar with it, but unfortunately in the aesthetic industry, the number one concern from a lot of practitioners is it safe, and I'm worried about necrosis and all these other problems, and that's purely because there's very little understanding about the in-depth anatomy of the nose, as well as also this fear-mongering that's sort of spread around by other practitioners about the risks of compression and direct occlusion because it's a vascular area. Now, for me, the nose is no more vascular than any other part of the face, really, if you think about it, because every part of the face has blood supply for it to exist, and things like the lips have just as rich a blood supply as the nose, yet we don't really worry about doing lips and worried about vascular occlusion. We generally worry more about cosmetic issues such as lumps and bumps, whereas when it comes to the nose, people specifically seem to be more concerned about vascular issues. And for me, if I was to have to choose a complication in a specific area of the face, if I had to have a vascular occlusion to manage, a vascular occlusion in the nose would be the one I'd rather have to manage than something, say, for example, in the temple or in the chin, nasolabial area, which are much more open, larger volume tissue compartments, where it's much more difficult to actually understand which vessel's been occluded, at what depth does that vessel sit, where does it sit laterality wise, and how much do I need to use to dissolve it accurately. Whereas in the nose, you can actually manage a vascular occlusion very quickly, you can pick one up very quickly, and they resolve very quickly when managed appropriately. And we're going to go through all of the considerations step by step shortly. As always, do drop your comments into the comments below, and we'll be having sections throughout the webinar where we answer those in detail. I'd love to know where you're from, and if this is the first webinar you've attended, or if you attended our previous ones, such as the one we did a month ago, which was full facial rejuvenation, or the one before that, which covered under eye or periorbital rejuvenation, tear trough fillers, mid facial rejuvenation fillers. Today's focus is going to be on non-surgical rhino, and I'm looking to schedule many more of these webinars for the US to come, and I'm considering doing, for example, one on specifically how to master lips, maybe one to cover specifically areas like the temple, the upper face fillers, forehead, frown line, glabella filler, as well as one to look at the non-surgical approach for chin and jawline augmentation for patients with heavier jowling, for example. There are lots of topics we can look into, but I'd really like you guys to drop into the comments what you're hoping to see from the future webinars that we're doing. Now, for those that have been really enjoying our webinar content, do consider signing up to Derma Hub. DermaHub.com is our online learning platform for aesthetic procedures. We have now around 100 hours worth of online learning. We've got a mixture of the live injecting webinars. These are lots of topics covered in the UK. For example, this non-surgical rhino one's already been done in the UK with 3 patients already a number of months ago. This is very much for the time zone of the US, so we're going to be doing this one again. But if you want to understand these areas in much more nitty-gritty detail, we have these live recordings, step-by-step treatment tutorials very much in a 4K quality videography studio, which we were able to cover, not a live session, we were able to actually get it to the point where we can make it a very standardized, simplified format to perform all of these procedures on a large number of patient cases. So you actually can see lots of different types of noses, from flatter bridges to dorsal humps to droopy tips to very active depressor septi muscles causing the nose to curve down. Brilliant. So just let me know where you're from in the US as well, just so we can kind of keep an eye on what kind of audience we're attracting, because it's really useful to kind of know, and then who we can focus more of these future webinars onto. Good. So let's bring our first patient in. Our first patient is Sabrina. We'll be able to go through a consultation together, and then we'll make out a plan as to how we're going to approach her nose. I'll go through the anatomy in detail so we can understand where is it safe, how do we make sure we're not increasing the size of the nose when we're filling it to minimize the problematic cosmetic outcome, and then we can go through the treatment together and we can see the results. Okay, so let's bring Sabrina through. Sabrina, if you come through, let you sit on the couch, you can lie down, make yourself comfortable. What we're going to do is we'll swap cameras to the mobile camera and we'll get Rachel to come in a little closer once it goes on the video. Cool. Okay, great. So Rachel, you come in. This is Sabrina. Sabrina, you sit up. And what we'll do is I'm just going to get the numbing products from the area away, and then we'll have a chat with the audience as to what we're looking to do. So this is, I believe, Sabrina's first time having a procedure like this. Just going to get another mic just for Sabrina just to hold, so when we ask them these questions, so you can talk and they can hear as well. Okay, cool. Let's give you a wipe. Oh.
I was like, what's going on?
I'll just let you take all the cream on there away. Lovely. Perfect. And I'll just give Sabrina a mic. There we go. Is it okay? Shall I long hold it?
Just hold it in.
Yep. Yeah. Cool, lovely. Right, so Sabrina, let me hold on to that. I'm going to give you this just to hold, so they can hear what we're saying. Lovely. So if you come in a little bit closer, Rachel, and what we'll do, Sabrina, is you have a look. You talk to us, me and the audience. I mean, we've already had a consultation off camera, but it'd be really interesting for the audience to understand what your goals are. So you talk to the camera.
Yeah, so I didn't want, like, my main concern was the front side. I didn't want it to look like big or like change, because they show you a lot of pictures from the side, but they never really show you the front. So I didn't really want it to change how my face like looked from the front. I want to get rid of the first, I guess, like dip, and this second dip, and I also didn't want it to like, I didn't want to have you said a masculine bridge. Like I didn't want it to be too like pronounced here. Yeah,
so we didn't want it to start almost like a Roman or an Avatar nose, which starts right at the top of the forehead.
Yeah, because I was like trying to see, like, I was on like Facetune and I was trying to see how it would look, and it kind of was like I couldn't really do it without it being like that, so I was a little scared. And then the tip of my nose, I didn't want it to like point up to like a Miss Piggy nose, like you said. I didn't want it to like.
We didn't want the nostrils to show, for example.
Exactly.
But we also don't want it to look a little bit droopy, because at the moment it kind of just turns down a little bit.
Yeah. Which I just, I didn't really care like if it wasn't droopy, as long as like if I had to keep it droopy for it to not have a Miss Piggy, I would.
Yes.
But if you can do it like up and like,
without
make it
Piggy,
not, then I'm more than happy to do that as well. But yeah.
Cool. Okay. So I'm just going to summarize that, Sabrina, for the audience. I'll just pop this on the side over here. Good. So if we come in, Rachel, let's just have a look at Sabrina's nose in close, in detail. And I'm just going to point out some things. Okay. So now what we can see over here, right, that's good, is we can see, if you just come in even closer, Rachel, that's good. Nice, okay. If we just come in a little bit to that way a little bit, that's it, and twisting around a little bit. That's it, perfect, good, okay, lovely. So what we can kind of see over here is we can see for Sabrina, she's complaining of a dorsal hump over here, a little bit of an indentation at the radix of her nose, at the top of the bridge. She's also describing a little bit of a saddle deformity here below the dorsal bump, and her tip is very soft, so it kind of curves or rolls down. And if you do a big smile here, Sabrina, when she smiles, it looks even more curved down at the tip of her nose. That's because the depressor septi muscle is pulling the tip down. So her goal is very much to straighten the appearance of her nose, but to keep it feminine. And a feminine nose generally has a little bit more of a natural upturn towards the end without showing more nostrils. And also from the front view, so if I just get Sabrina looking a little bit this direction towards the camera. Now from the front view, if we can capture it dead on, we'll see Sabrina has a little bit of a curvature over her nose. So she's noticed that it almost kind of has a little bit of a curve over her bridge and then her tip over here. And she wanted to see if we can straighten her bridge out a little bit more from the front view, but she also doesn't want us to increase any width. We don't want to increase any size of the nose, and that's a common concern for patients when they're having filler, because we're actually technically adding filler, or we're adding product to the nose. And now I'm going to talk about how we can cosmetically keep the size to a minimum while actually improving the shape and the outcome or the silhouette of the nose as well. So this is what we're working with. So it's a really nice case to demonstrate some of these techniques. Lovely. Sabrina, any questions?
No. The only thing I did forget to say about the curve of the nose, but I was scared about it. Yeah, yeah, it's true.
Cool, right, so you lie down, make yourself comfortable. Okay. Okay, cool. So I'm just going to get you shuffling down a little bit so you can rest your head on the headrest. Brilliant. And what we'll do is we'll come in really close then, Rachel, just so we can have a good look over the nose here. Good. And I'm just going to, at the beginning, so we can see the side view of the nose here. Let's just wipe some of this down. Good. Now, is there a way, Caroline, we can just reduce maybe the brightness? There's a very bright shine to the nose. It's okay on the camera. Ah, cool. Okay, no worries. Okay, lovely. Right, so if we have a look, if you come a little bit lower then, Rachel, that's it. A little bit more this way. There we go. Okay, and let's come a little bit more there. Perfect, okay. So things to consider. Now, no patient wants us. I'll let you close your eyes for a moment there, Serena, just so we can get your eyelashes out of the way. Brilliant. Now, no patient wants to have the Radex built up so much that it looks like their forehead and their nose is completely merged together, right? So we don't want to cause this kind of appearance where we have an avatar nose or the nose looks like it's connected to the forehead. So that's one thing we don't want to do, and that's very commonly done. The number one concern that a lot of practitioners have when it comes to noses, and this is misplaced concern, is about this theory of filler-related blindness from nose filler. Now, if we talk about that in detail, and I'm going to talk about the anatomy in a moment, there's an area of the nose, if we just mark out the intercanthal line between the eyes, or the canthi of the eyes, there we go. And if we come a little bit higher now, Rachel, a little bit over the top of the nose, that's it, keep coming up a little bit. There we go, lovely. So we've marked out the intercanthal line. Now let's see if we can kind of come around a little bit, maybe this way, here maybe, does that work? Or do you want to stand from above that way? Yeah. That's okay, cool. Good, so we've marked out the intercanthal line, and what that demonstrates is where the frontal bone completes and where the nasal bones begin. Now remember, the nasal bones, we have two halves, so let's just divide this across here. We've got, and we can actually palpate and feel the edge of the nasal bone over here. Running over there and running over there. And there's our nasal bones. We've got the frontal bone is going to come in. We've got the orbital rim or the socket, either side. There we go. And we have blood vessels such as the supratrochlear artery and some other vessels. So let's talk about those in a little bit of detail. Other structures, so before we mark up the vascular supply, so below the top half of the nose being bony, the bottom half of the nose is very much cartilaginous. So you can see how flexible and moldable that area is, versus the top of the nose will move the whole patient's head much, much firmer. So we have some cartilages, so we can mark out the cartilages with blue. We've got our medial crus cartilage. There's the two. We've got our upper lateral cartilage plates. And then we've got our lower lateral cartilage plates. There we go. So that's very much the anatomical pattern of the nose. Now, if we build it up layer by layer, we'll start to understand that we're looking to change the soft tissue that is resting on these structures. So the skin and the subcutaneous tissue, the SMAS, all resting on these cartilage plates or the bony plates. Now, we have vessels that come into the nose. I'm going to talk about those in detail, as well as vessels that go into the forehead itself. And there is a specific distinction between where those vessels arise. So let's first start with the vessels that come into the nose, and then we'll come on to this concept of why people are worried about blindness and things, and how we can keep it, completely avoid it and be safe. So if I just turn a little bit to the side here, Sabrina, there we go. I'm just going to get you to clench your teeth together. There we go. That's the anterior border of her masseter muscle. Let's go a little bit more that way. Okay, we're going to have our facial artery coming along over here. We're also going to have coming from the external carotid. The external carotid will continue off across to supply the temple area. As the facial artery comes up into the face, we're going to have a superior labial, inferior labial, columellar branch, which is important to consider when we're doing the nose. And then we're going to have our angular artery coming up just outside the nasolabial, but it can be in the nasolabial fold in a certain percentage of the population. Now that artery at the top here runs superficial, and it's going to give a branch that runs up into the nose over here and starts to supply sections of the tip and the lower bridge. We also then, we'll see it coming off into the infraorbital foramen over here, but we may also get anastomosis with the external nasal artery over here, or sometimes the dorsal nasal artery. Now, these arteries very much run superficial. Right, so we have the lateral nasal, external nasal, or dorsal nasal, LED, much easier to remember. The LED arteries, or nasal arteries, are running superficially, so they're running in the subcutaneous SMAS layer, rather than running in the deeper planes, such as the periosteum or the perichondrium, the cartilage levels. So to avoid puncturing those vessels, what we want to do is make sure all of our filler is placed very precisely in the smallest quantities needed to adjust the shape of the nose, on either a hard surface such as a cartilage or the bone. Now, people end up doing these injections onto the bone, and they're coming down and they're doing these injections along here, and they end up going into this area that's above the intercanthal line, where there's a little bit of a transition. We have our supratrochlear arteries that supply coming off into the forehead, and these arteries actually have a communication retrospectively into the central retinal artery. So there's a common branch that occurs, and then it goes off to become the central retinal artery, or then there's another branch that comes off and becomes a supratrochlear artery, and we're talking here intracranially. So where the supratrochlear artery overlaps, you can kind of see, is that when people are injecting on the bone higher up here, it's a very periosteal artery. Now, if I use slightly differing colors to mark out the depths of these vessels, and I use green, is that showing up green on the camera? Yeah. Green to demonstrate a deeper artery, so we can see where the deeper arteries lie, which when we're injecting nose filler and we're going deeper, we want to avoid going anywhere near deeper arteries. There. A deeper artery over here, deeper artery with the lips, and the columella. And when you get to somewhere mid-angular artery, and I use yellow to represent superficial arteries, that shows up yellowy, yeah, a little bit yellowy. Good, and we can see that we've got lateral nasal, external, and dorsal nasal more superficial, whereas the infraorbital is periosteal. So now we can start to understand that when we're placing, if we come in a little bit closer here, Rachel, there, so we can get the drawings in a little bit more. That's it, just turn a little bit towards us there, Sabrina. Perfect. And if we just come a little bit higher, so we cover a bit more of the forehead. That's it, lovely. So when we're treating the nose, we need to make sure we're staying away from the nasal arteries, which are superficial, so we place our filler deep. But there's this point of the intercanthal line where the nasal bone ends, and we're coming into the frontalis, the frontal bone of the glabella. That's where the arteries for the supratrochlear are periosteal. So there's this complication that I've seen a number of times all over social media, as well as a couple of real cases where practitioners who often tend to decant their filler into a BD syringe, and they tend to go down to bone, and they'll bolus here, they'll do lots of micro droplets all along the bone, claiming that's safe. They almost don't realize that the point that they go above the intercanthal line, it becomes too deep. and they're placing filler around the areas where the supratrochlear arteries are periosteal. And if you're very much then relying on the actual anatomical variation of the patient, if those supratrochlear arteries run more centrally rather than laterally, and you're placing your boluses centrally, you can end up filling the artery. The amount of volume it takes in the supratrochlear artery for the filler to then end up spreading all the way up to the central retinal artery is 0.157 ml. So just to write that down here, 0.157, we're talking a very, very small amount of filler in that area for it to track all the way back into the eye and cause an issue with vision. So how do we avoid that? Well, if we mark up the intercanthal line and we stay below that line, i.e. in the nasal bones and in the perichondral cartilage of the nose, we're not going to run into problems such as blindness because we're not going above that area where the supratrochlear arteries are arising. So we give ourselves that safety margin. How can we improve that safety margin even more? Now, let's not start up here where we need a lot of filler. So I get Rachel to come a little bit more on the side, Rachel, now. That's it. There we go. There we go. We can see the outline of Sabrina's nose now. So now I've got the option. I can fill above this way. And when I do that, you can see there's a gap. I'll get my pencil in that gap, right? So in that gap there, we can go in and drop some filler to straighten the nose bridge out so it looks like it's merging the whole way along. If I fill in that area there, I'm then increasing my risk of complications at the top of the nose bridge, which blindness is one of them, and I'll give the patient also a masculine looking nose. This is the area not to start injecting at the beginning of a non-surgical rhino, and this is often how a lot of people learn non-surgical rhino, is just by straightening the area around the bump. That's a very poor or a low quality non-surgical rhino. The opposite approach we can take, right, so that's the one that a lot of people are doing and they're filling in that gap there. If we instead go this way and we have a look now, I can get a straight nose by filling below the bump here. So by elevating the tip and elevating the lower part of the nose like this, we can get a straighter, feminine, shortened nose, where by elevating the nose tip just from here and not adding volume up here, I can actually shorten the length of the nose, because the nose will still start at the frontal nasal angle over here. And what I've done is I've decreased the length of the nose by shortening the nose up this way. So it's getting shorter, rather than if I fill up here, I'm actually lengthening the nose. So that's a really important consideration. So for safety margins, let's start at the base of the nose here. We're going to actually come to the anterior spine of the septum to shorten the length of the nose and fill in the crus, or the tip of the nose, then the saddle, and then the rhinion area, or the dorsum of the nose here, the radix, comes last. And that gives us the reduced amount of volume needed up here to straighten the nose. And sometimes you don't need any volume here to completely straighten the nose, because you've actually straightened it from below the dorsal bump. Now, it's always worth having a look when you're treating the nose what the highest point is. And in the case of Sabrina, the highest point is the dorsal bump. So what I need to do is, instead of filling above the dorsal bump in there, I'm going to go for filling below the dorsal bump. And if you look at it now, technically, from the dorsal bump below, the tip is a little bit weaker for Sabrina. So it's lower than the dorsal bump. So we need to elevate the tip, elevate the saddle, that meets the dorsal bump, and the whole structure will look feminine and straightened. And that's how we want to approach a nose. So I'm sure that stimulated a lot of questions. Just so that people can take a screenshot, Rachel, can we do the overhead and we just spin it round a little bit? That's the one. There we go. So that's a really nice anatomical photo to consider taking. So you have the green representing next to the arteries, the deeper arteries, the yellow representing the more superficial arteries, and understanding the anatomy of the nose from a structural perspective, as well as where the vessels end. Okay, good. So, how are you doing, Sabrina? Okay, I mean, I don't want you to miss out. Do you want to have a little look at the cool photo?
I was wondering what was happening.
It's just a colouring.
Oh my god, that looks crazy.
Yeah, it comes off.
It's fine. It looks kind of cool, actually.
It looks quite cool, right?
Yeah.
Is the Halloween costume ready? Good, okay, so let's take all that down, clean it all down, and then we'll come on to product. So, what I'll do is, Caroline, any questions coming in? Where are they from? Have they seen the other webinars? Any topics or webinars they want us to do?
Yeah, good question. We have people from all over. We have Nicole from Texas. We have someone from Jill's from Atlanta, Georgia. So, and we've got Lisa from Philly. We've got Artem, who has brought DermaHub annual expert option and is very, very happy.
Oh, cool. Yeah.
So that's very nice to hear. Not too many questions yet. We have someone asking about if you will cover Botox in this area as well. I don't.
Yeah, I can do at the end. Yeah, I can do a quick little recap of nasal Botox.
Could you use a cannula to reduce risk factor?
So, good question. I knew that question will come up. Of cannulas. So, when it comes to cannulas I find very effective in certain areas. When it comes to the nose, there's a very small category or percentage of patients that need a cannula nose. And it's usually those that have no bump. And I'll talk about why in a moment once I've cleaned the area down for Sabrina here. Because it's something where I've seen a few occlusions happen in a nose because of a cannula. And you'd think, wow, how? Cannula's meant to add safety. But in the nose, it can actually reduce safety if you're using it for the wrong reason. And I'll talk about that in a moment. Good, okay. So good to see so many of you guys joining the webinar. Hopefully it's useful. This is an awkward time because there's so many time zones in the US, whereas when we do it in the UK, everyone's in the same time zone. We don't have to worry about EST and CT and PT time. Too many times. Mountain time? I don't know, you guys got too many times. Okay, cool. So let's talk a little bit about product and instrument to deliver the filler. Now that we understand the anatomy, now that we understand the order we're going to place or the locations we're going to place product, we can start talking a little bit about actually where we're going to go from instrument and perspective of product. So first things first, what are we going to use? So now when it comes to using product, if you come in a bit closer, Rachel, really close, keep coming in, there we go. We're going to use Teoxane, or supplied by Revance, RHA4, which allows us to use a very high density product into the nose, because what we don't want to do is we don't want the filler that we're placing in the nose to start migrating down the side of the nose. We also want the lowest phase angle. Now when it comes to rheology and noses, phase angle is very, very important. Phase angle refers to how much product do we need in any area of the nose when we're injecting a little droplet to change the actual way the skin drapes over the structure. So if we need a very small amount of filler to get a straight nose, right? So imagine if we had Sabrina and her identical twin, and we use two types of filler. We use, for example, we use something like a Juvederm Voluma, or we use an RHA4. RHA4 has a much lower phase angle, so we could do both noses. One with RHA4 would have a straight nose with a much smaller physical volume of filler, versus Sabrina's identical twin, who would have the same nose, but the same outcome would take a lot more product when it comes to something like Juvederm Voluma, which has a much higher phase angle. And a higher phase angle is the opposite of what we want. We want a low phase angle when it comes to non-surgical rhinos. But that equally applies to when we're augmenting chins, cheeks, jawlines. We want to have a filler that's able to project the structures that we're injecting into, the soft tissues, off the bone and off the actual physical structures, so we can use a smaller quantity of products, i.e. our filler economy, the amount of filler we need, is much better, and we can get a better result for the patient, i.e. in the nose, a smaller looking nose that still looks straight and sharp without having to use a lot of product. So that's the advantage of using something like RHA4, which still has a very high viscosity, which means the migration is much lower. More viscous fillers migrate less, softer runny fillers migrate more. And then the other thing is it's a dynamic filler. So should you over-inject the droplet, you can still mold and blend it down quite nicely. It's forgiving in that nature, which something like Juvederm Volux isn't, which is very, very rigid, but it doesn't have that dynamic component to be able to mold and manipulate it before it integrates into the tissues. Longevity-wise, I see my patients typically looking about 18 months to 2 years for their non-surgical rhino result before they come back for an adjustment. Now, when they come back for their adjustment, usually about 1.5 years to 2 years, they only need a very small touch-up or a maintenance visit rather than the full procedure again. And when you have a 1.2 ml syringe, this is something that you can actually decant, and you can often treat 2 patients or 2 noses with a decanted filler in 0.6 and 0.6. So it's very economical, and it's something I definitely would recommend looking into the RHA line. Good, so that's our product. Now then let's look at the actual instrument. Feel like I need 20 hands. So we're coming on to our cosmetic cannula. So this is not the needle, this is just what they're asking questions about. We're not using this, Sabrina. It looks scary. I'll let you close your eyes if you want to. So if we come in closer then, Rachel, we'll go for the overhead view for this one. Now this would be a cosmetic cannula. Now if you have a look, this is a 27G. You can use a 25 gauge or a 22 gauge. I mean, that is very much up for debate as to which one is effectively better as a cannula of choice. But let's just look at the principles. It's a very short cannula, it's 38 millimeters, which means I can get to the top of the nose quite comfortably. Now, for patients that want to straighten the nose, like Sabrina, which is the vast majority of non-surgical rhino patients, they often have a bump, right? There's the bump, that's the rhinion, or where the bone kind of protrudes out a little bit. And we know the plane we need to go into. We need to be deep on the cartilage, and then we get to the bone, and we stay deep on the bone all the way around. Now, if I were to try to do Sabrina's nose with a cannula, I would start off here, I'd try to go in here, and I'd try to go in deep. I would then keep the cannula buried on the cartilage, gliding along the cartilage, and it will get stuck when it gets to the bump. And you can kind of see that. If we come from the side view now, Rachel, just so we can kind of see that. Let's see if you rotate around a little bit, there we go, perfect, good. And from the side view, you can see it would get stuck at the bump. Once it gets to the bump, it gets stuck, and it's not able to overtake the bump, so you end up flattening the cannula to try and get the tip to come up. And as the tip comes up, you get over the bump. It goes from being deep to being actually quite superficial. Now the cannula on its own won't then bend back down and go back underneath. What will happen is it will stay superficial. And I've seen a few cases of practitioners who've used a cannula in the reason of safety, and they've actually ended up causing an occlusion by ended up cannulating either the supratrochlear artery and causing a problem with reticular mottling and pallor over here, or they've ended up causing a problem with the cannula tip curving down the side of the bridge of the nose and the filler kind of just leaking down the bridge here and giving a very wide bridge. So what we want to do is, the only patients I will use a cosmetic cannula is when there's no bump at all, when I know I can stay deep the whole way along, and it's usually patients have a very flat bridge. So Afro-Caribbean patients or Oriental patients where they have no bridge, or they want to build up the bridge to give them a very slim light reflex along the nose, a cannula allows you to do that with fewer entries with the needle. So you can go in and you can leave a linear thread on the way out, and it will build up a very nice slim bridge. But for Sabrina, the bridge is not the problem, it's actually the bump and the droopiness of the tip. So in those patients, we want to be super precise with our droplets of filler, so needle wins in those cases. So I generally am a needle person when it comes to injecting most non-surgical rhinos. In the very few cases where I use a cannula, it will be a 27 gauge cannula for those that need a bit bridge building. Good, hopefully that answers that question. So we've now understand where we're placing the filler, deep, because the arteries in the nose are in the SMAS, superficial. We also understand the product we're using, high G prime, high density, but with a low phase angle and with very good dynamic properties. So we're going to use RHA4, and we're going to be using a needle for Sabrina because she doesn't need bridge building, which is where the cannula wins. We need to have precision so we can reduce the amount we're using. So we also understand the points we're going to inject. So let's recap those, and we'll then start doing the markings. We're going to be injecting at the base of the nose septum there. That's going to be number 1, and I'll talk about how we find those. Then we're going to mark up the cruce, which is going to be number 2. Then we'll do some in the saddle, which will be number 3. And then possibly, if we need it, we can do a number 4 at the radix at the top. So that's our order of injecting. 1, 2, 3, and then 4 to get the result. Now, how much are we going to use? And I'm going to talk about those in detail step by step. Good, okay, so a little bit of sterilizing solution here for you then, Sabrina, okay? How you doing?
Good.
Okay.
I cannot look at that needle, so
Oh, it's gone?
Oh,
That's
no,
not what
I'm
you're
just
using?
saying,
Oh,
I'm
the
just
one.
gonna close my
Oh,
eyes.
yeah, that's fine. That's fine. Good, okay, so let's actually mark up the nose design, or the landmarking I use for the nose. So the number one and most important drawing to do is the intercanthal line. So let's mark that up. There we go, marked it up. We're going to mark up the septum on this side and the septum on that side. If we just get chin up a little bit here, there we go, we can see those drawings, good. We're now going to follow those septum all the way up to the top of the nose. So let's going to mark up this lateral bridge. And that keeps me focused centrally, because that's what we want to do. We don't want to inject the filler off center, because A, it will just widen the nose, has no cosmetic purpose, but also then you run the risk of going into more of an arterial territory with the main branches running laterally. Good, okay. There we go. So we've got a nice slim section of where we can fill here for Sabrina. Let's turn her a little bit towards the camera. There we go. Is that showing up okay on the video? Yes? The drawings? Cool. Now, I'm going to mark up the rhinion, which is actually the dorsal bump. So I can see that's the end of it here. It starts and it kind of raises up here, then it kind of drops off again. So that's where we don't want to go. Then we've got this little saddle area of the tip here. So we'll just mark up where the tip finishes, and there's a saddle. So there's some windows where we want to fill. Let's shade these in here, yellow. So where we want to look at filling is in this area, maybe in this area at the end if we need a little bit. And then structurally, what do we need to do? So those yellow points are just very much a case of just tissue blending. We're just trying to blend the light reflex in these areas and merge the two areas together with the bump. But the actual structural changes we need to do some filler underneath, and that's going to go under the anterior spine onto the maxillary crest, and I'll talk about that in a moment. And we also need some in the crus to give her a light defining point on the tip of her nose, and also to have the nose overtake the bump on the nose. And by doing that, by elevating the nose tip, means as it overtakes the dorsal bump, we can use a little bit of blending filler in between here to merge the new tip up to the bump, so the whole nose from the side looks nice and straight without needing to put a lot of filler up here. Okay, good, we're doing brilliant. Okay, so let's carry on over here. So the next section we're trying to mark up here is just the top of the nose here. We're marking up the peak of the two nostrils just along here. And what we want to do is we want to use that as our entry point. We want to make sure we go in here to get up to just here. And by getting up to that point there, that's our needle, it's going to allow us to build up the crus. So why do we need to do these two injections? So if we just catch the side view again then, Rachel, that's good. We're looking at the angle of the nose over here. So we're looking at the philtrum column. That's the philtrum column. We're looking at the septum. And we can see for Sabrina, it's very much a right angle over here. That's what we want to get an ideal male angle for the nose septum. What we want for a female angle is a little bit of upturning on the tip here. So by a little bit of upturning, we want to get to a 110 like this, rather than a 90. So if we can do a little bit of product here, we'll get it to the 110, which will mean her nose elevates without having to put too much filler at the top of the nose. The other thing it also does is it allows us to relax with myomodulation, this muscle here, the depressor septi, that then when she smiles, naturally causes the nose tip. As you see, what it will do is it pulls the nose tip down like this. So when they smile, they know their nose tip kind of droops down and gives them more of a curved or a hooked nose. So that's the two purposes we want to do that. So what does that look like? So we've got the septum running on the nose, we've got the maxillary bone, and we have this very small space. So you can imagine that's the septum over here, that's the maxillary bone. If you come around a little bit on the front here, Rachel, we want to get our needle directly underneath this gap here with this anterior spine of the septum, and we're going to get to this landmark called the maxillary crest over there. So by getting our needle down to that point, when we bolus here, it acts like a lever, and it causes the whole nose to lift up a little bit here. So that's the approach we're taking over here, and that's going to be coming in on there. Now when it comes to vessels, these columellar arteries actually get severed when you have a surgical rhino, the surgeon, an open surgical rhino I should say, will make an incision directly along here, and they'll cut through those vessels. And when they do the whole nose surgery and they put the skin back and they suture the area in, they don't restore those arteries. The patient can live, just like you can live without your appendix or your gallbladder, you can live without your columellar artery. So this is an area when you're injecting deep down to the anterior spine over here, you don't have to worry about aspirating, and it's a very safe area to bolus underneath here. As long as you're deep and you're touching the periosteum, you're safe. So that's where we want to go down to, and we want to bolus here, and that's going to give us a lift and stop the nose from flaring down. That will reduce what we need in the tip, because what can happen in the tip is it's a very tight compartment, the nose. So we can cause a compartment syndrome, which manifests as a compression in the nasal structures. So the skin can suffer and can go into ischemia and necrosis because you're not allowing blood to flow into the nose because of the pressure internally in the nose and the compartment of the nose because of the filler we've added. So we want to use very small amounts of filler. So here we're going to use 0.2 to open the angle by about 5 to 10 degrees for Sabrina, 0.2 ml. Whereas when we come to the tip, we're going to use 0.05 ml in the cruce, 0.05 ml in the saddle, and maybe even just a drop, even less than 0.05 ml in the radix to finish the whole nose. So we should be able to do it in 1, 2, 3, 4 injections, maybe even less. Good, okay, lovely. Right, so just going to get some equipment ready. What I'll do is Sabrina, do you want to do your thing? Mm-hmm. Yeah. Any questions so far, Caroline?
Yeah, we have a few. What is the Tinkerbell tip lift? Alexis S is asking.
We'll actually demonstrate that on Sabrina because we're doing her cruise or that Tinkerbell. I mean, I don't think it's a very professional thing to call it a Tinkerbell tip. I just call it a tip lift. But for your patient, I just kind of call it a very feminine tip, which works better than a Tinkerbell tip. Tinkerbell's a cartoon character. We don't want people to have cartoon noses.
Okay. Is Voluma a good product for the nose?
Voluma,
Yeah.
I would not recommend for the nose. It is very volumizing and it will cause the nose to appear bulkier or more fuller and not sharp and precise and contoured. So using a softer filler is much better. Using a more viscous filler is much better. Something like RHA4. Other possible options, I mean, the US is limited in high density fillers. Do you have a Restylane lift?
Yes.
Restylane lift would be the only other option I would say in the US works really well.
Okay. We've got Amanda asking, would you suggest nose tox prior to filler? Would this reduce the amount of product needed?
I wouldn't recommend actually nose toxin. By using nose toxin, for example, in the depressor septi, it wears off very quickly. You end up using a small dose in an area where the muscles around the mouth can weaken, so you don't want to use too much a dose. You end up using something like 5 units into that muscle, stop the nose from moving down or flaring down, and all that's going to do is last maybe 12 weeks. Whereas the filler, the mind modulation, will last about a year before the nose starts moving again when they're expressing. So actually it doesn't help at all. Filler will win. Cool.
PDO thread nasoplasty question.
Yes. PDO threads, okay, so yes, they can't occlude a vessel, right? I get that. Filler can occlude a vessel, get that. PDO threads are also dissolvable. There's no evidence to say they leave any lasting collagen of any significant amount to cause the lift to stay. So although when the suture goes in and it pulls the nose up and makes it look a little bit different, it doesn't really fill in gaps between the bumps. It just will elevate the nose tip, and all it will do is, after a period of 6 to 10 weeks, dissolve and the nose kind of falls down again. So patients who have come to my clinic for nose filler have usually sometimes considered or tried PDO threads and been very disappointed. So for me, not worth the hassle to offer that. Filler, when done well, always wins. Cool, right, so let's come back to Sabrina, and I'm just going to show you some of the needles I'm going to be using. Now the filler, RHA4, comes with 27 gauge, 13 millimeter TSK needles. For me, these don't control the flow very well. You can extrude a lot of filler through these needles very quickly and make the nose look bigger. So instead, I want to have more precision. So I'm going to be using a 30 gauge, 13 millimeter needle. You can still always stick with the company TSK, they sell a box of those yellow needles. This is a filler needle rather than a Botox or a toxin needle. So it has ultra thin walls, so the extrusion force is actually still quite good with a dense filler. It doesn't hurt your hands or it doesn't feel too hard to inject. but the hole at the end of the needle is still very small. It's still 30 gauge, means I can get the flow of the filler to be smaller and more precise, more comfortable for the patient than a bigger needle. And also, it allows me to avoid increasing the size of the nose by injecting more precise, smaller quantities. So that's what I'd recommend using, and that's what we're going to use now, is going to couple the 30 gauge with the syringe. Good, so we've got it screwed on. I can see the bevel on the end. I'm actually going to mark up on the hub where the bevel sits, so I know exactly where the bevel is. Even once I've primed it and I've got filler on the end, I just need to look for the white line to know where the bevel is, because it's really useful to have the bevel pointing up when doing nose filler, so you can reduce your quantity. Good, okay, so we're ready to go. So, 5-minute procedure. Very, very quick, very, very simple. So a little bit of cleaning solution here for you. There we go. Okay, good. Right, so let's get your chin up a little bit over here, Sabrina. Okay, how are you doing? Mm-hmm. Okay? This is when you get onto a roller coaster and the straps come down and you're like, I queued up for hours for this. Mm-hmm. It's fine, you'll be fine. Mm-hmm. So what we want to do is we want to be a ninja in the nose. I always say we want to be a ninja because we want to have the best cosmetic outcome with the least amount of filler. So every single injection should be done with meaning and purpose. So the first thing we want to do is I prefer to hold the syringe and I want to inject from the hip. So I've got my elbow rotated in rather than out. Okay, so I've got it in and I'm holding it below. If I hold it above, my elbow has to come out. So we're going to hold it in and I can inject from the hip. It gives me more stability. I can also rest my finger on the chin. The other hand, we want to have the ability to feel and palpate the area. So the first injection we're going to do is in the maxillary crest down here to just open up the angle a little bit, stop the depressor septi from pulling the nose down when she smiles, and give her a very nice nose even when smiling and expressing. So we want to go in with our karate chop, resting on the forehead. We want to then come in, and if we just come around a little bit, Rachel, just so they can see underneath here. Perfect. I'm just using my fingers to pull the nostrils away and pinch the septum in here. It distracts the patient, but also allows me to lift the septum off the maxillary crest. We're going to go in precisely, and the landmark we want to use is very much where the surgeon will make their incision. So if we get a pencil to feel where the septum ends, right? So I can feel the septum here, it's quite hard. I can feel the septum in here, and I can feel it either side. And when I get to this point just under here, there is a gap between the septum and the maxillary bone. So that's actually where we want our entry point to be. So we're going to go in, pinch, lift, and we're going to get Sabrina to use her mouth to breathe so she doesn't hold her breath for a long time. And we're going to go in, and we want to feel the bone as we go in. So nice deep breath here, Sabrina. Bit of a pinch. Well done, that's it. There we go. So you carry on breathing. We're going in, we're going in. If you come from the side a little bit, Rachel, so they can see my angle. They can see it's about a 20-degree angle from the lip. I'm going in, I'm going under the septum. I've wandered the whole needle in, well done. A little bit of pressure for Sabrina there, we're in. We're just resting on the bone here, and we're going to bolus. We're going to put 0.2 ml in this position. And that's going to allow us to open up that angle there. So nice and slow, because we don't want rapid expansion of the tissues. It is uncomfortable for the patient. So 0.1 in, we're going to put another 0.1 in, and we'll be at where we want to get to. Now here you can use up to 0.6 for very droopy hooked noses. So for those that have a nose that really collapses down like this and you want to open up the angle, you can see now there's so much support now. Even if I try to push it down, it flicks up and we're at a very nice open angle now. So if we were to go back and have a look at our angle, you can see now we've gone past the 90 degrees and we've actually gone up to 110. That's where we want to be for Sabrina. So that's the first injection done, and we got exactly what we wanted from that injection. So we can discount that first zero.
Not bad.
It was okay, right?
Yeah,
That's actually the worst one in the whole nose.
Oh, good, thank God.
So that 0.2 we can discount because it's not externally making the nose any bigger. It's going internally, so it's actually not changing the size or the bulk of the nose whatsoever. It's just being clever in myomodulating the depressor septi. So if we smile now, Sabrina, you see how our nose does not move at all, and relax and smile. It's fixed. Okay. Feels strange for you because it's numb now? Feels a bit weird?
Yeah.
It wears off soon. Okay, good. So the next injection we're going to do is we're going to go in just at the peak of the two nostrils like we talked about earlier. So if we come around, Rachel, just so they can see the drawing, so peak of that nostril, we're going to go in the middle of there. Once the needle goes in, remember, we have to get over the two crus cartilages either side. Once we get between the gap of those, we get the needle the whole way in, we're going to rest about here. So if we come to the side here, Rachel, they'll be able to see. Once we're at the entire length of the needle in, you'll see the tip is resting there, and we'll bolus. And we'll bolus 0.05 ml per injection until we get the tip to where we want it. So it's about that kind of quantity of filler. If we can come in close to, so that they can see, Rachel, just that little tiny droplet of filler there. That's kind of what we're going to do, but that's going to be deep. We don't want to inject it in the skin, so we don't want to see the skin blanching. We don't want to see the filler eroding through the pores. What we want to do is we want to be perichondrial on the crus cartilages so that we can actually project the tissues up and lift them off the cartilage and create a new light reflex on the tip. Okay, so let's do it. So first things first, let's pinch and see how much room is inside the tip. So I'm just untethering the skin from the cartilage there, so I can see, I can tent the skin off the cartilage. There's some room. I can deglove it almost. And by being able to do that, I can see there's not a tight compartment. Patients have had a surgical rhinoplasty who then come for filler, and I see quite a large number of them. Because of the surgery and the adhesions and the scar tissue underneath the skin is almost fused to the cartilage and the bone below, which means that any filler you place in there can cause compression very quickly as a compartment syndrome because there's almost no space at all to put filler. So you have to be very careful and use very small amounts in those patients, whereas Sabrina, I can see there's lots of room here. It just moves very nicely, and I can separate the skin from the cartilage. But I can also, at the same time, assess the capillary refill. So I can see her nose is a little bit cold, but her cap refill is still 2 seconds. So I know the cap refill at the beginning of the procedure in the tip was 2 seconds. And that shows me there's good perfusion there. So let's go in now, separate the skin. We're going to go in straight into the nose. So as I go straight into the nose, deep breath here, Sabrina, a bit of a scratch here, pinch. I've just touched the cartilage, so now I have to flatten and go a little bit over the cartilage, and I'm curving around over the cartilage, so I keep deep. Once I'm in, I can see I can elevate the tip of the nose, I can create a nice elevation. I haven't injected anything yet, but I can't see the needle tip blanching the skin, I just see it tenting the skin, which is where we want to be, we're deep. So I'm going to keep my fingers either side. So if you just come around a little bit, Rachel, this way, there we go, and come over the top a little bit, and come in a bit closer. That's it, really nice and close to the tip. There we go. So I'm pinching either side, and we're going to give her a little bolus, 0.05 ml. Good. I'm keeping it pinched, and I'm going to come out, and we're done there. Good. Still doing okay, Serena? So if we come back to the side view now, Rachel, let's see what it's done to the tip. So someone asked about a Tinkerbell tip. Tinkerbell, there you go, that's a Tinkerbell tip. It's just a small flick on the end of the nose, or a little tiny little kind of cute little tip. So what we've done is we've elevated the skin there. So now if we just turn Sabrina to the side, if we come a little bit lower, Rachel, there we go. A little bit lower, just use the black background, that's it. If you come a little bit higher actually, because it's just coming out the camera. And we're going to get it trying to focus on the nose there. If you just, that's good, yeah, cool, there we go. So now we can see we've got a lovely nice flip. It's almost completely straightened out the bump. Just by rotating the base and the tip, we've almost made it look completely straight at the top. So we've not had to inject the riskier area at the top. We've done it all from below where it's safer. And we've used 0.2 internally, and we've used 0.05 externally, so the risk of even compression is low, the risk of increasing the size of the nose is low, and the risk of causing a direct occlusion is very low. So that's a very nice approach. So now, for some patients, they might want to soften that transition there. So I'm going to put a little droplet of filler to soften that little bit of a saddle here, and then we can do, if we need to, anything at the top to finish off, and we're done. So 2 injections in, we're almost done. So now we're going to come from behind. Actually, I'm just going to do a touch more in the tip, just to go a little bit higher just so we have room for the saddle. So nice deep breath, 0.025 more, just to get the tip a touch higher. There we go. That's it, okay. So we're now 3 injections in. Okay, so we can see the tips now even more projected. There's more of a saddle, so I can put a little droplet of filler, and the droplet of filler will literally go directly in that area there, that gap there, if we come in closer there, Rachel. And that's just going to smooth out that transition between the new tip and the saddle and the bump, so it looks completely smooth and straight. So we want to go in here. So now, my approach here is if I go 90 degrees, right? If I go 90 degrees and try and go onto the bone there, there's no bone. The bone is much behind it. So in this area is the cartilage. If I was to go into the lateral cartilage plates here, I would just risk the needle going directly through the cartilage, which is painful for the patient. And you can do intranasal filler, i.e. the filler is extruding out inside their nostrils. And the patient then blows their nose the next day or later on, and the filler comes out and they say, oh my God, I saw a snotty filler and it's blood stained, and then the nose bleeds, and then you panic that the bleeding is because of vascular occlusion, but it's just because you've gone into their nose and made a hole in Little's area and they've got a nosebleed, a traditional nosebleed. So we want to avoid that. So what we can do is we can go in at a shallower angle like this. By going in at 45 degrees, we can touch the cartilage and we can graze the cartilage better rather than puncturing the cartilage at 90 degrees. So 45 degrees here is a much better approach. So I'm just going to get my hand just around the camera here. So I've seen where we want to go. We want to just go exactly here. So I'm going to measure a needle length away so I can go first onto the deep plane. So we're just lifting up the skin here, lifting it up. So I'm separating the arteries which are in the skin away from the cartilage underneath. We're going half the needle in at 45 degrees, and I can feel it now scraping the cartilage, so I can lower the angle down and go all the way along. And now that I've got into that little gap, I can leave a little tiny bolus. We're talking 0.001, or very small, hardly any actual amount at all. Good, okay. So we're getting there, it's almost there, just a little bit more. So we're going to come in, leave another little droplet, and we'll be done here. So nice deep breath here then, Sabrina. That's it. Are you guys enjoying this content? Is it useful? Am I going into enough detail? Angles, amounts, anatomy, all of those things? It's really important because it's one thing to understand how to inject. It's another to be able to impart that knowledge. Okay, good. So we're there. Good. So let's look at both sides. Let me check the other side for you then, Rachel, as well. Good, we're getting there. We need a tiny bit more. So now, if we go dead in line here, we can see, can you see it on camera? Oh, I was trying to cover it up. There we go. It's almost completely straight. There's just a very small indentation here and a very small indentation here. So we're going to fill those in, and then we'll answer any questions you may have, and we'll show you the final result as well as Sabrina. So it's a case of just going in very precisely, leaving droplet by droplet for what you need to get it straight, rather than over-injecting and then not getting the result you want and trying to then mold and massage it down. Good, so it's lovely and straight from the tip all the way to the bump. And the only thing we've got left now is just a tiny drop in the radix to finish it off. Let's see if we can get my uniform to cover that there. There we go. It's looking very, very nice. Okay, how are you doing, Sabrina? Maybe the last injection now. Okay, so we're coming into the radix now. So instead of having to inject this area loads, we're just going to do a droplet, and we're talking about something like that, 0.05. Hardly, I mean, it's so small you can barely even see it on the camera, that little droplet. Just there. Okay, good. So let's go in. Deep breath here, Sabrina. Pinch. Well done. So resting on the periosteum of the nasal bone there. Dropping it there. We're below the intercanthal line, so we're nice and safe. And then just wiping, compressing and moulding that filler in onto the bone, and we're done. perfect. Sorry, you probably saw my face zoomed in looking at the area. Let's see the other side. I'm just going to get you to shuffle a little bit to the side, Rachel. Nice, we're done. Okay. So I'll show you. I've got to wipe it down first. Yeah. How was it, Sabrina?
It wasn't bad. The only part that hurt was,
That bit at the bottom. Yeah, that's it. It's a weird one, that one is, but
then after you get used to
the rest is fine. Just going to wipe it all down. So just going to get your chin up a touch. Chin up a little bit, just so we can wipe these drawings down. So I'm sure some of you have some questions. I'm going to answer those in a moment. I'm going to let Sabrina get back to what she's got planned. All finished, all done, Sabrina. We'll show you first. Cool, right, so let's sit up a little bit. Okay.
Everyone in the comments is saying you look beautiful.
Oh my god, I look the same.
Yeah, your face hasn't changed.
Oh my god, guys, this is great.
So, I don't know if you can see it there. Do you want to see your side view, Sabrina? No, it's even easier.
Oh,
Just look at the camera.
Oh, straight.
Just look straight. Look at that. Yeah.
Oh, I was
good.
like, why am I so red? Oh my god.
Oh, sorry, I got the drawings.
Wait, pause.
That's good, right?
No.
There, look,
Sorry,
you can
guys.
see
I
against
need
my
to check
uniform.
different faces. This is crazy.
Really
Oh my
straight,
God, thank you
so
so much.
sharp. Looks so good. Even when you smile now, it doesn't droop down.
I know. Let's wait. Can I see them?
That's good.
That would look so weird.
Yeah. So we've got it lovely and straight, lovely and sharp. You can see all the angles. It looks really crisp. It looks very natural.
Yeah, it does.
But it still looks like your nose,
I
but just
know.
perfected almost, isn't it? Tweaked.
I'm so scared.
Yeah.
Wait, is that me?
Just there, you can see it better.
Oh my god. Oh, I'm like shocked right now.
I
can't
know,
believe
it's come out so good. I mean,
Yeah.
just so we can show off to the audience, I'm going to get you looking straight ahead. So there we go. We can see her light reflex now is much straighter from the front. It doesn't look as wavy or curved because we brought the tip in line. We filled the saddle, and by connecting the tip saddle to the dorsum, we managed to give that illusion of a very straight nose from the front. And if we turn and come cut to the side, if you look straight ahead there, Sabrina, and we have a look at her side view, you can see now, big smile, no droop, and looking straight, just relaxed. Nice and straight, no actual dorsal bump, and also with a frontal nasal angle, it's still very feminine. We've shortened the distance of her nose by elevating her tip. Looks really nice.
Oh my god.
Okay, cool.
My mom's gonna be like, what?
Well, when it heals, it'll look better.
Yeah.
Avoid sunglasses and glasses for the next 3 days because you will just dent the filler we put in the nose.
Oh my god, this is great. I need your card. Oh, but this will go down, like the swelling, right?
A little bit of swelling there because of the injections, but that will calm down. No bruising, it's nice.
I know.
Yeah.
I was like, oh my god, thank you guys.
No worries, thank you very much.
Thank you.
Okay.
Wonderful.
So that's the actual live injecting part done. So I'd love to answer any questions you have. I didn't cover one thing, which was just the nose tox, but I'm going to cover it using one of our team members, just so that Sabrina's not being kept here forever and ever. And then we can go through and recap the Botox that we can do in the nose as well. So that way we've covered filler and toxin in the nose, as well as then also why not to do threads or other procedures that kind of claim to give you a surgical straightening of the nose, but they don't really do that, if I'm honest. So let's come to any questions we might have, Caroline, and then we can answer those.
Yes, we have a lot of people asking about aspiration, that you did not aspirate.
I did not aspirate, and I don't aspirate when I inject, apart from when I do the gunshot on the temple. That's the only injection in the whole face I'll aspirate for. And in the US, aspiration is considered gospel. Everyone thinks it's the thing to do. Now remember, it's one tool in a whole arsenal of tools to reduce the risk of a direct occlusion, i.e. the needle piercing into the artery and then filling the artery with filler, which is what we don't want to do. A gel will behave like a clot and reduce the flow of blood. Now, if you think about it, every injection I did was touching a hard surface. So I was touching the bone, the cartilage, the bone, and the cartilage in the saddle. The vessels in the area, and I know the anatomy of the area because I do a lot of scanning and ultrasound, so even though I didn't scan this patient in particular, it applies to most patients. 90% or more will have the standard variation of anatomy. So when we're looking at the nose, we know that the artery, even after surgery where they can have migration, vascular migration, vessels coming in different locations, they might move side to side. They don't change plane, i.e. when they start off superficial in the nose, after surgery they stay superficial. So I know for Sabrina, her arteries are going to be superficial. So as long as my needle isn't superficial, then the risk increases. All of my injections are very small, precise boluses, right? The biggest bolus we did was 0.2, and in an area where even if I aspirated, it wouldn't matter. So for me, I don't aspirate anywhere, i.e. so my positive aspirates have been 0, because I don't aspirate, right? I don't get a positive aspirate because I never really do it. So, but my vascular occlusions are not high at all. So if I was seeing a lot of vascular occlusions, it would mean then I'm just not aspirating and then I'm missing the arteries and I'm just bolusing inside them. What a lot of people do is they panic because they aspirate and they see a bit of blood. That could be venous. That could be just you having gone through an artery, cause a little bit of a hematoma on the inside if you aspirate it, and you're just sucking up the blood that you've made leak inside the face. So you don't really know if you were directly inside a vessel. And as an anesthesiologist by background, when we do arterial lines, I understand how difficult it is actually to go in with a precise needle, palpating an artery, such as the radial artery, and trying to get the needle into the artery to leave an arterial line in there is not easy when you're even trying to do it on purpose. So the odds of me doing it by accident, even across thousands of patients, is very low. And even if it happens in the very small cases, right? I've got colleagues who aspirate everywhere, and I say to them, have you ever had a vascular occlusion? First of all, it's a numbers game. You can't avoid every vascular occlusion. If you inject enough patients, you will see one. No matter if you just use 22 gauge cannulas or if you aspirate in every injection you do, it defeats the purpose, because by aspirating, I still got colleagues who have had a negative aspirate and then have still bolused and managed to occlude a vessel. Now, they've done a long aspiration, 10 seconds or more, with a 0.2 ml plunger pressure back. But the problem is when you're injecting a high density filler. Now, if I show you the filler here, I mean, in the end, we only used 0.4 ml from the 1.2, we've gone to the 0.8. So you can see easily I could have done 2 patients. If I decanted this into different syringes, I could have done 2 noses with 1 filler, which is a really nice thing with the RHA, the phase angle we talked about. But this needle, after the first injection, is primed through the hub, all the way through the shaft of the needle up to the bevel. So if I'm now trying to aspirate fluid, right, through a gel in the shaft of the needle, the odds of me actually being able to suck a liquid through the thick filler is very low. So there are a lot of cases where you may be, there have been cases from colleagues where they're actually in the artery, they're sucking back and they're not able to suck the blood through the thick filler in the shaft or the hub into the syringe, right? They're pulling, they can't get it through, so they think that they're safe and they bolus and they end up causing an occlusion. Remember, they're manageable, so we want to reduce and be as safe as possible, and the safest thing we can do is intercanthal line, inject below that, so you're not in the frontal bone or into the supratrochlear arteries. You inject from below and work up to the radix, inject small quantities on hard surfaces. So then in that case, we've got all the other safety there. Aspiration won't add any safety. And now if you really feel comfortable, you can. For me, it just makes my patients more uncomfortable. And no matter how safe, you can do a one-handed aspirate, and you think you're really slick at it, you're still going to move those micromillimeters, which defeats the purpose. You go in, you aspirate, and then you go move your hand around and pinch, and then by the time you've done that, your needle is now not touching the bone, and then you have to crunch back on the bone, and now that aspiration you did was pointless, because now your needle is physically in a slightly different position. Do you got to aspirate every single time you keep moving your needle? It's impossible. So for me, it doesn't add any benefit. So that's why I don't aspirate, and you can see it doesn't actually risk any problems. And if you would love to see more of that, do have a look at our hub webinars, the other ones we've done. Look at our hub content. Come do a training course with us. We're here in the US every month. Next month we'll be in Dallas. The month after that we'll be back in Miami. And we run training courses for professionals like yourselves, only medical professionals. And we're able to teach you non-surgical rhinos, under-eye rejuvenation, full facial rejuvenation, basic procedures from toxin, lip fillers, you name it. We have a course for every procedure out there, all the way through to glabella and temple and even roof or supraorbital filler. And that's very much hands-on. Small group training with a trainer like myself and my colleagues, maximum of 4 to 5 students with a list of models. For example, we ran 2 lists today, and each list had at least around about 7 to 8 models, and we're talking around about 40 syringes of filler per list or per group, because we're doing full facial rejuvenations. So there's a lot of hands-on practice to really conquer and master these techniques and feel comfortable to take them away, rather than watching someone like me inject on stage, there's a fly in the room, and then actually not being able to go away and do it on yourself in your own clinic. So you want to be confident, come and learn on our training courses. Have a look at dermamedical.us is our website. if you want to come on and watch more of these training videos or more of my previous webinars that you might have missed, or my actual treatment tutorial videos on professional videography level, www.dermahub.com. Follow us on our social media pages, so derma_medical or Derma Medical USA are our Instagram accounts. If you want to follow me specifically, dr.tiara, like the crown, you'll see me come up and you can follow us personally, as well as then also look forward to our future webinars in the US, which will be showcasing more procedures in a much more detail like you saw today, to kind of show you some new approaches to get a better cosmetic outcome like we achieved, with better filler economy, smaller amounts, because your patients are always on a budget. They can't afford 15 syringes, but they want that result 15 syringes give. So how do I use 6 or 4 or 3 to get double the amount of syringes worth of result with less product? Now that starts with using something like an RHA filler, which gives you better filler economy, but also modifying your techniques to get the best bang for your buck from every drop of filler we're injecting into the patient's face, all while doing it in the maximum safe approach. Good, so hopefully they enjoyed that. I mean, hopefully I've answered that age-old question of aspiration I get on every webinar I do.
Yes, I think you have.
Okay, all right, so how long are we, what are we doing for time?
We are at 9:11.
Okay, all right, okay, we've done pretty well.
Yeah, we have more questions if you want to.
Yeah, let's do a few more questions.
Yeah.
I'm going to save the Botox for a Botox-specific webinar where we go through everything facial Botox wise in detail, because it needs that kind of detail and that time, and I need to go through the anatomy in detail, talk about exactly every landmark for nasalis, nares dilator, levator labii superioris equinasi, periorbital Botox, DAO, mentalis, masseter, as well as for temple Botox, frown, you name it, we can do it all in one webinar. So if you'd like to see that, drop in below in the comments, Botox webinar please, and we can organise that soon. And let's do a couple more questions, Caroline, before we wrap it up.
Okay, we have Claire who was wondering, she said she's been told that there is more risk for occlusion at the tip of the nose, but what she's hearing now is that the top portion of the nose is riskier than the tip.
Yes, so the dorsum of the nose is where the blindness and the more concerning occlusions can happen. The reason people get occlusions more often in the tip in terms of frequency, which are less worrying, because a tip occlusion is not going to cause blindness, that's going to be somewhere up here, but what they're doing is they're not checking the compartment, the tip is tight, right? They're injecting too superficial, and what they're doing is they're causing those vessels to not be able to perfuse the tip because the pressure in the tip from the filler. So to avoid that risk in the tip, remember, go deeper onto the cartilage in the tip and use smaller quantities with a better quality filler, where you can actually get the tip to change the projection and the lift with less amount of filler. If I'd gone into Sabrina's nose and used 0.3 ml, right, or 0.2, that would have caused a compression on her tip and caused the problems with tip perfusion, but I used 0.05 on the first one, then I went back and did 0.025, so I used less than 0.1 in her tip, which at the end had no problems with compression or occlusion from the pressure inside the tip. So that's a worry people have with tips, is they're using too much volume.
For someone with a more curvative nose than Sabrina, would you just feel slightly more on the opposite side of the curve?
Yes, so if there's more of a deviation from the front, i.e. it's curved more, the side of the bridge that's missing, all right, so opposite to the curve, you need to fill in to actually give the illusion of a straighter nose. Now, I've actually got some of those cases demonstrated on both our training courses when we go through the slides, but also on the hub. You can actually see me go through some deviated noses and how to approach those in more detail. So we've got lots of nose videos on there as well. So look at signing up to the hub to see more of that. But yeah, that's kind of what the principles are, going off center.
Okay, lovely. We only have a lot of requests for a Botox webinar now, so yeah,
cool.
that's it.
Okay, excellent. So hopefully you enjoy these webinars. I'm looking forward to seeing some of you on the training courses. Looking forward to seeing some of you joining the hub. If you join the hub, you get an annual membership, so a year's worth of access to the videos. Think of it like a Netflix/TED Talks for aesthetics, where we have a subscription-based membership. You have access to all of our treatment tutorials, all of our webinars, historic and future. You can watch it in your own time. You can rewind, record, you can ask in the members group any questions, and me personally, as well as my injector trainer colleagues, will answer those and any questions you have. We also have a mentoring for your business, so I can go through the business side. We have tutorials and trainings on the business side, so how do you actually attract more patients, how do you book those patients in, how do you retain those patients, and how do you grow your business from a business owner's perspective, rather than just focusing all about the actual complications, which seems to be everyone's concern as an injector, which is understandable, but we equally need to know how to put those treatment principles into practice and actually turn it into a profitable business and grow that business, so we can see on a weekly basis 20, 30, 40, 50 patients and be full-time injectors rather than part-time injectors dabbling in multiple specialties, which tends to be where the majority of the industry is. Good, okay, so www.dermahub.com, sign up and access more of this content. If you want to come on a training course with myself or my colleagues, dermamedical.us for the US audience. We also have dermamedical.co.uk for the UK and European audience. We have dermamedical.net.au for Australia, as well as launching soon in the Middle East / Dubai, India area. So look out for that too. Thank you very much for joining us today. Really appreciate having you guys on the journey with us, and looking forward to seeing you again very soon.